So we'll be covering hepatitis B. If you have a question, you can just type on the chat, then I'll try my best and answer them. Okay. So hepatitis B, group 5, 6, 7. Group 7, one thing you have to know or you have to remember about hepatitis B is that it is double-stranded DNA, but it is partially double-stranded DNA. Okay. It belongs to the family Hepad DNA viridae. Hepad DNA viridae. The genus Hepad DNA virus. Species is hepatitis B. Okay. So if you remember Hepad DNA, so it is a DNA virus, and then it is partially double-stranded DNA. Okay. As you can see here, this is a very high-yield image. You'd be drawn for a picture like this, then they'll label here double-stranded partial with partial single strand. You know that this is hepatitis B. It has an envelope, it has a capsid, here it is. And then there are these antigens that we're going to go through all of them, and you have to understand so that you get the hepatitis B serology. We have hepatitis B surface antigen, are these ones. Okay. Then we have hepatitis B C antigen, which is the core antigen, this one, where the capsid is. And then we have hepatitis B E antigen, these ones that are floating, okay, the ones in black. Then we have the envelope, okay. So the three main antigens is surface antigen, which is HBS, E antigen, which is HBE, and then C antigen, which is core antigen, which is HBC. So that is something you have to know. You can be brought to a picture like this, and then you're told to label, okay? Yes, so this is just the same picture. It is spherical and elongated, as you can see here, okay? And then it has three distinct morphological entities in various proportions as seen. They are small pleomorphic spherical particles around 22 nanometers, most abundant. Then we have the tubular ones, which are 200 nanometers long, and then the complete HBV viron. Okay, so there's this, and this. These are the morphological entities. But the most common is this, the spherical one. And then, as I had mentioned, the antigens. So we have HBS antigen, HBC antigen, and HBE antigen. And then any point or anytime you see the word anti, we are meaning antibody, okay? So this is antibody against the HBS antigen, antibody against HBC, antibody against HBE, okay? We're going to go through all of this. Then I'd like to mention about something about the viral replication. You see, for hepatitis B, it's quite unique. We have entry into the cell, where this is the common one, where all viruses enter the cell, and then they fuse, okay? This is the common one. So what type of cell is this? What type of cell is this? Where viral replication, or which type of cell does viral replication take place in the hepatitis B virus?
Is it the hepatocyte?
Hepatocyte, very good. So this is a hepatocyte. So the hepatitis B will come. Then the one responsible for fusion is the surface antigen, okay? There is a receptor, it will attach here. And once it does that, it will fuse. And once it fuses, it will enter the cell through endocytosis, okay? Once it enters, the viral envelope, remember, it has an envelope here, okay? So once it has entered, the viral envelope will be removed, and the nucleocapsid, you see the capsid that was here, will be transported to enter the nucleus. Okay, so this is the capsid containing the genetic material, which is the partial stranded DNA. It enters the nucleus. Okay, so this is the uncoating phase. We were done with the attachment and entry phase. Then from here, you can see here it's written cccDNA. So this cccDNA, it's called convalently closed circular DNA. So I don't want to get into so much detail because it is very low yield, but basically what happens here is there'll be conversion from rcDNA. So rcDNA stands for relaxed circular DNA, the double-stranded relaxed circular DNA that comes here. Then it will be converted into this, the cccDNA, convalently closed circular DNA, okay? And then this one will now act as a template for transcription, okay? So have you understood? The partial stranded DNA will be converted to cccDNA, which will act as a template for transcription. Then from here, transcription occurs. So the RNA polymerase transcribes this into viral RNAs, okay? Then we encode for certain proteins. Now the proteins that we know, HBS, HBC, HBE, okay? Once that happens, we go to translation. Now translation is where now it's translated into the exact proteins. So the capsid protein, HBS, okay? All the proteins that we know, okay? So what is happening here is there'll be assembly, all the proteins that have been encoded will assemble into one virus, and then they'll be packed together, then they'll be recycled, and then they'll be released, okay? Now this is forming the new HBV virus, okay? So it is released from this hepatocyte via exocytosis. So it entered via endocytosis, exits via exocytosis, okay? So basically that is the viral replication cycle. So the take home I want you to have from this viral replication, what you most likely are going to be asked is, number one, hepatitis B has a partially double-stranded DNA. Number two, in this process here, I didn't mention, because I didn't want it to get complicated. We have the use of reverse transcriptase enzyme. And then number three, the viral envelope does not come from the cell membrane, okay? It comes from the endoplasmic reticulum, okay? The envelope of this virus, that is very unique for hepatitis B. It comes from the endoplasmic reticulum, okay? And then we have routes of transmission. So as I had said, anytime you see hepatitis B, hepatitis C, remember how HIV is transmitted. It is transmitted the same way. Vertical transmission, so this means mother to child. Sexual transmission, sexual contact. Parenteral transmission, so it can be through blood transfusion, body piercings, tattooing, IV drug use, needle stick injuries, or even household contacts. Okay, so these are the razor blades, the nail cutters, the toothbrush, but it's not spread by saliva. So razor blades, so let's say you use this razor blade and you cut yourself while using it, I might get hepatitis B. So blood is the main fluid it is transmitted via, okay? So this is the epidemiology age. So the chance of developing acute hepatitis is directly related to age. So acute hepatitis is the disease that is caused by hepatitis B. So perinatal, 1%, early childhood, 10%, late childhood, 30%. Now, for it to develop to chronic hepatitis, it is inversely proportional to age. Perinatal, 80 to 90%, early childhood, 30%, late childhood, 5%. So a very small child is more likely to develop chronic hepatitis compared to acute hepatitis. And hepatitis B is a very serious disease. If you come to your clinical years, you're going to see how much it affects people. It may even progress to hepatocellular carcinoma, which basically means liver cancer, okay? So here is the flow chart. Let's say you've got exposure of hepatitis B, you develop an acute infection, then you can get acute hepatitis. When you get acute hepatitis, it can cause subclinical disease or icteric disease. Subclinical means that you're sick, but it is subclinical. Sub means below. So it is below par. You're not going to get that sick, okay? Most likely you're going to recover. But icteric disease is now where you get features of hepatitis infection. So icterus means jaundice, okay? So jaundice is the yellowness of the eye. So subclinical disease, greater than 90%, most likely you'll recover. Less than, this is 0.5 disease, you're going to get fulminant hepatitis. Then in less than 5%, you're going to get chronic hepatitis. And when you get chronic hepatitis, there's a 2% of recovery. 30% or more, you'll be a healthy carrier state. And then 12 to 20%, you'll develop liver cirrhosis. And once you develop cirrhosis, there's a 6 to 15% chance of developing hepatocellular carcinoma from the cirrhosis. So as you can see, this disease is easily treatable. We have antivirals that treat it. So the chances of you getting cirrhosis or hepatocellular carcinoma, they're quite low. They're quite low. The chances are quite low since we have vaccines and we have drugs that treat this disease, okay? Then the clinical manifestation, incubation period, 30 to 180 days. As you can see, it has a very long incubation period. It is indistinguishable from other hepatitis viruses. What this means is hepatitis A virus, hepatitis D, and hepatitis E. Not D, sorry. Hepatitis A and E, they all have short incubation periods. It should be weeks. But hepatitis B and C, the incubation periods are long, okay? You can see this is 1 to up to 6 months. Then the pre-icteric phase, as I had said, this is before you develop any jaundice. You get non-specific symptoms, nausea, vomiting, joint pain, okay? Those are the non-specific symptoms. Then the icteric phase is where you get jaundice. Hepatic complications, we have fulminant hepatitis, cirrhosis, and hepatocellular carcinoma. Okay, so this is the end stage for this disease. I don't know whether you can see, my slide looks so small. So I want to explain the serology first, then I come here because you'll easily understand the serology first. Okay, so just to mention, collection, transport, and storage of specimen. HBV infection is diagnosed by serological and molecular methods using serum and plasma. In general, HBV antigens and antibodies are stable at room temperature for several hours to days, can be stored at 4 degrees Celsius for months, and can be frozen at -20 degrees to -70 degrees for many years, okay? This is just a by the way to mention. Then for the lab diagnosis, okay? This is a very common picture. You will see it in so many books, okay? You will see it in your exam, okay? They can just block this, block this, block this, block this, block this, and then they ask you, what is the serology? Because all of these are serological markers. HBS, AG, anti-HBC, anti-HBS, okay? And I want you guys to understand it. So the first thing is, this is something you should have in mind. I hope everyone is listening, okay? Number one, antigens. So antigens are HBS antigens, HBC antigens, and HBE antigens, okay? This, and there's no HBC antigen, I'll explain. But antigens they rise in acute disease, okay? And they fall when the infection resolves. That is the first principle I want you to know. Antigens rise in acute disease and fall when the infection resolves. When I get the disease, let's say I've shared a needle with someone who has hepatitis B, that is the acute phase of the disease. If you take my blood sample, you're going to find antigens, okay? Then antibodies, they rise when acute infection resolves. What does that mean? When you're getting better, when you're getting better, the immune system is working or you're taking drugs, antibodies now start rising. The level of antigens will fall and the level of antibodies will rise. Okay, those are the two principles I want you to know. If you know that, understanding this would be very easy. Antigens rise in acute disease, fall when the infection resolves. Antibodies rise when the acute infection resolves. Okay? That's what I want you to know. Okay. So before we start with this, let me start with this. Hepatitis B C core antigen, you will never see this as a marker. This is because we cannot detect this in plasma. Okay? So anytime you see an MCQ or a question where they're saying HBC antigen, just know that is false. You can never detect this in plasma or in the serum. Okay, the reason is it is an intracellular antigen, so it is secreted within the hepatocytes. Okay, non-secretory hepatocytes by immunofluorescence. So in plasma, you will not find this. That is the first thing out of the way. So have you understood that? Type on the chat if you've understood. So anytime you're explaining to your friend why you will never see such a marker is because they're finding hepatocytes within the cell themselves. Okay, now let's go to this. Anytime you see someone with hepatitis B, the hallmark of infection, either acute infection or chronic infection, is hepatitis B surface antigen. Now that is something I want you to remember. It is the hallmark of this infection. Okay? Whether you have acute infection or chronic infection, this is the hallmark. Okay? Is that okay? Yes, good. So it appears in 1 to 12 weeks of infection, or 8 to 12 weeks. It indicates onset of infectivity. Becomes undetectable 1 to 2 months after jaundice, used to calculate prevalence. So I'm going to explain that. From this picture, I want you to notice something. There is something written here, core windows. We call it the window period. Can you see here? Between month, this is like 4.5 to 6.5. Okay. Can you see here? Let's say around 4.5 to like 6.5. Core window or window period. So remember we said antigens are present when the acute infection is there, and antibodies are present when you start recovering, when you resolve. Now that is the period where we call window stage or the window period. Okay, don't confuse it with the window period you might know, the window period where we used to call it incubation. We used to call it window period in, I think, primary or high school, where we meant incubation period. Incubation period basically means where you get the disease, but you don't have symptoms. No. What this means is it's the period between this hepatitis B surface antigen falls and the antibodies rise. Okay. So why is this important? Someone has said I repeat, please. Okay. Are you seeing here written core windows? Core windows is also known as the window period. okay? It is the stage between the fall of hepatitis B surface antigens and the rise of the antibodies. Remember I said antigens are present when acute infection is there, and antibodies are present when you start getting better. You're resolving. So that is the period. Okay? So why is this important? The reason this core windows or the window period is important is because hepatitis B surface antigen will not be detectable in blood. Okay? If you were to get this person, remember this point has said, becomes undetectable 1 to 2 months after jaundice. So that means in this person, let's say I get hepatitis B virus, then after 5 months, remember I said hepatitis B surface antigen, this one is the hallmark of the disease. So when I get this disease, after 5 months, this one will have disappeared. Okay, because my immune system is fighting this virus. And this one will now start reappearing. Okay, now, but in this window period, this one has disappeared, but this one has not started reappearing. Okay, so if you were to do the serological marker, you will find this one is absent and this one is absent. So you might confuse and say, this person doesn't have hepatitis B. Are you understanding? So that's why this window period is very important, because it indicates absence of this and absence of this. Absence of this because it has got lost, like you're recovering from the disease, so this will be absent. And then you have just started recovering, so this is still absent. Are you seeing here? Level of detection is 0. You will not detect it. This is now the window period from here to here. Okay? Now, what happens is you cannot assume this patient does not have hepatitis B. So there is a special test we do. We call it anti-HBC. So antibodies against HBC. This is very, very, very useful in this stage. Why? Because remember, in antibodies, we have IgG and IgM. Okay? The ones that show acute infection is IgM. The ones that show chronic infection is IgG. So that is something I want you to remember. So in this stage, the window stage here, we do, okay, I want you guys to tell me, do we do IgG or IgM anti-HBC? From my explanation, do we do IgG or IgM? Let me see answers on the chat. So that's good. We do IgM, okay? So the only sole marker present during the window phase or the window period is anti-HBC IgM, okay? That is the only one, okay? I hope we've understood. We have understood this point. Becomes undetectable 1 to 2 months after jaundice. We have known the reason. And then one thing about HBS surface antigen, the hepatitis B surface antigen is it indicates the presence of the virus, okay? So if it's positive, you know that this person is infected. Remember I said it is the hallmark of the infection. But it does not necessarily indicate replication. So you might have the HBS antigen, but does not indicate that viruses are replicating in your hepatocytes, okay? HBE antigen. HBE antigen and HPV. Please repeat IgG versus IgM, okay? So IgM is used to indicate, these are immunoglobulins or antibodies, and they're used to indicate presence of an infection. An infection might either be acute or chronic. An acute infection is IgM, and a chronic infection is IgG. Everywhere else, you'll see antibodies against anything. If you see the presence of IgG, that is a chronic infection. If you see the presence of IgM, it's an acute infection. So I want you to remember that always. Okay, both in virology, microbiology, immunology, everywhere. See IgM, you know that this is something that is very acute. If you see IgG, it is very chronic. Okay, I hope that's clear. For the hepatitis E antigen and HBV DNA, these are related. How are they related? Hepatitis E antigen. If you see this marker, it just indicates viral replication. If you see this, I usually remember by saying E, hepatitis B E antigen. It's a marker of infectiousness. Okay, the E here is infectiousness. Okay, so they are markers of active viral replication. So if you see this marker, you'll know that, oh, replication is happening. And then high viral infectivity. So this is a person, if you see this marker, you'll know that this person, if they go, let's say they have sex with someone, unprotected sex, they can easily transmit the virus, okay? And then why so? You see this hepatitis B E antigen? This one, these black dots we saw here. Here's that picture, this one. They are secreted by these infected cells. So this cell, once it gets infected, these ones are the ones that will be secreted, okay? So remember when replication is occurring and they are pumping out these viruses, so it will start secreting this hepatitis B E antigen, okay? And once you see hepatitis B E antigen has risen, the level of HBV DNA will also rise. They are concurrent, okay? Once this rises, this one rises. Hepatitis B virus DNA basically it detects the viral load. What do we mean by viral load? Viral load means the amount of viruses in your blood. Okay, so when this one rises, replication is occurring. This one will also rise because the number of viruses are increasing in number, and it cannot differentiate stages. Yeah, it's basically a marker to know how many viruses do you have in your body, so that we determine the course of treatment. Okay. And then get to that. This one. Antibodies against this. So what that means is you're clearing, this one is clearing from your system. Okay. So it indicates diminished replication and decreased infectivity. Okay. So when you have antibodies against this, what will be your hepatitis B viral DNA? Will it be high or low?
To be low.
It will be low. Very good, because we said they act concurrently. Good. I'm glad you enjoy your understanding. And then, so we are done with this. We are done with this. We're done with that. Hepatitis C antigen, I had explained why it's not detected in blood. And then the antibodies against. So for IgM, appears 1 to 2 weeks after hepatitis B surface antigen and lasts for 3 to 6 months. Indicates acute infection. So this is where you see the 3 to 6 months is the window, at that window period. So this is where you'll get this as the sole marker of the window period. And then IgG appears in the late stage and remains positive indefinitely, a chronic stage, carrier stage, and recovery. So let's say no replication is occurring in your cells, no infectivity is occurring, you're okay. When you're recovering, this will be there, okay? And then total anti-HBC, negative. So if it's negative, indicates that a person has not been infected with hepatitis B virus. Makes sense, isn't it? Because if you have been infected with hepatitis B virus and you're okay, you will have to have the antibodies. Okay, but if it's not there, we'll know, this person has not been infected. Then acute, okay, so we are getting there. In an acute disease, hepatitis B surface antigen will be positive. As we had said, it's the hallmark of the disease, whether acute or chronic. And then IgM anti-HBC, mostly in the So this will be positive except in the window period. This will be positive all the time, even during the window period. And then hepatitis B E antigen can also be positive if replication is occurring in your cells. And then if it has resolved, remember we said antigens are not present when the infection has resolved. So this will be negative. In a chronic person, it will be positive. Okay. Then this one we have understood. Anti-HBs, these are antibodies against HBs. This one we have explained, have we? Appears after clearance of hepatitis B surface antigen, remains indefinitely, indicates recovery, immunity, non-infectivity, marker of hepatitis B, vaccination. So I want to explain that. So as I had said, hepatitis B has a vaccine. It's a recombinant antigen. So if you are being injected with an antigen, what will your body produce? What will your body produce? Will it produce an antibody or an antigen? If I inject you with an antigen,
It will produce an antibody.
it will produce an antibody. Very good. So if you've been vaccinated, the only marker that will be present is this is the antibody that will be present. You cannot have hepatitis B surface antigen because you have not been infected. So this is the only marker that will be present. Okay, so as I was saying, occult hepatitis B infection, it is very unique in that we have positive hepatitis B, but we have negative hepatitis B surface antigen. And we know this is the hallmark of the infection. So when this is not there, you're wondering, oh, how is this possible? As I've written in the chart, we have two types of OBI, occult hepatitis B infection. We have seropositive, where anti-HBC and or anti-HBS are present. So where is it? This will be present, or this will be present. That is seropositive OBI. In seronegative OBI, only the DNA is present. Okay? Okay? So have you understood on OBI? It is quite a unique scenario. Occult means something that is hidden. Where you'll use occult mostly, you'll hear someone say occult blood in stool. So this means that the person is not, releasing stool. They're not passing stool in their blood, but once you do some tests, you're going to find some hidden blood in that stool. So that's what we mean by occult blood in stool. So similar to this occult hepatitis B infection. It is not, the hepatitis B surface antigen is not present, but you have hepatitis B infection. Okay. And then the last question, markers of chronic infection. What are the markers of chronic infection? So a marker of chronic infection, I said anytime you see antibody against hepatitis B surface antigen, you know that is someone who has resolved. So a marker of chronic infection, we have hepatitis B surface antigen. You can have hepatitis B E antigen if you're highly infectious. Remember, it's a marker of infectiousness. And then you're going to have anti-HBC, but now you'll have IgG. Okay, you can also have HBV DNA, because it's just a marker of viral load. So if you have high viral load, you're going to have this. Okay. In summary, HBS antigen. If it is positive, this person is infected, regardless whether it is acute or chronic. If it is negative, this person is not infected. That is the summary I want to give you. Okay. I hope you've understood the serology. I had a picture here. Let me go through it. So these are the HPV markers at different stages. We have susceptible or a negative, early incubation. So these are the earliest stage. You'll see this is positive because it is a marker of viral load. So you might have maybe 2 or 3 viruses. So it is there. Then late incubation, this will be positive as the viruses are increasing. So incubation is when you have the viruses, but you do not show symptoms, okay? This will be positive, okay, because it is a mark of acute disease. Then this might or might not be positive because this is just a marker of infectiousness. Then the rest will be negative. Then we go to acute infection. This will be positive, this is positive, this is positive, this is positive, okay? Anti-HBC IgM. Remember, this one is positive. It starts being positive here until the window phase as it continues. And then recent infection. So recent infection, this means you had it and then now you're okay. This might be there or not. It depends. The viral load might be very, very low. So maybe it's not detectable. And then IgM will be there. The reason is it's a recent infection. Anti-HBC will be there. Okay. And then anti-HBE, it will be there. Remember I said, if you're recovering, the antigens will not be there. The antibodies are the ones that are going to be there. And then this will be positive, positive, positive because you've recovered. And then remote infection, negative or very low, okay? It is very, very low. And then here the anti-HBC will be there. Anti-HBE, positive or negative, but anti-HBS will be there, okay? What is this? HBS, negative acute infection. So this is the one we are calling OBI. This will be there, this will be there. That is the seropositive one. And then if it's seronegative OBI, this will be positive, but this one is the seropositive one, okay? HBS, virulent infection. So let's go here. Vaccination response, only this will be positive because I'm injecting you with the antigen, okay? So I'm going to send this slide. You study this and try and understand, okay? Okay, so from here, I think we're okay. We were here, detection methods. So we have the antigenic, molecular, serological, biochemistry, microscopy, and culture. These are the detection methods used in. Markers of chronic, repeat please. Okay, so let's go to this chart. Where was chronic? Is chronic here? We don't have chronic here. No worries, but I'll explain. Remember I said, if you're having a chronic infection, this is someone who has this will be there. Hepatitis B surface antigen will be there. It should be there because I said this one is present regardless of the infection, whether acute or chronic, okay? And then we will also have this. It depends. The level of HBE will be, it will be there because the function of this is just to show infectiousness, okay? Because it's secreted by infected cells. So it will be there. So if it is there, it means that you're highly infectious. If it is not there, meaning you're not infectious, okay? And then the DNA, it depends. It only shows viral load, the amount of virus in the blood. So if you have a chronic infection and you have a lot of viruses in your blood, this would be positive. But you might be someone who has a chronic infection, but the viruses in your blood are not that many. So this will be, it will show a low viral load, okay? Then this should be there, anti-HBC, but IgG, okay? Because it is a marker of chronic. This will not be there because IgM is a marker of acute. Is it clear? I hope it's clear. What of marker for someone who has been vaccinated? As I said, someone who is vaccinated is injected a recombinant antigen. So if you have been injected an antigen, you expect your body to produce antibodies. So the only marker that will be positive in someone who is vaccinated is hepatitis B, surface, antigen, antibodies. This one. Where is it? This one. Anti-HBs. It is a marker of hepatitis B vaccination. Okay, because you're injecting me with the antigen, and remember, I've never gotten the disease, so I'll only have these antibodies. Hope that's clear. Any other question on serology? Okay. Where were we? Okay. So microscopy, so these are the detection methods. Microscopic detection of HPV does not play a specific role in diagnosis. However, a liver biopsy is typically used to assess the extent of histological involvement and damage, as well as response to therapy, okay? The issue with the liver biopsies, they're very, very invasive. So you go, put, and then take a biopsy is a specimen of the liver. So basically you go check under the slide and see what is the extent of damage and if your liver is responding to the therapy, okay? So microscopy doesn't play a big role. Culture, although HBV can infect hepatocytes in vitro, culture of HBV is not used for the diagnosis of infection. So this is not even done, okay? Then we have antigen detection. So this is what we were doing, all those markers. A marker of active viral replication is the detection of hepatitis B surface antigen and or HBe antigen during primary infection and during chronic HBV infection. Both the antigens are produced in excess by the infected hepatocytes. So you can use ELISA, immunochromatography test, enzyme immunoassay, radioimmunoassay. It detects greater than 0.1 nanograms per ml. Okay, so most commonly done is ELISA. Okay, and then hepatitis B surface antigen, this one. Remember, this is the one that it is the hallmark of the infection. Approved by the FDA for diagnostic use only. Any specimen non-reactive to HPS are considered negative and do not require further testing. Those reactive must be repeated to verify the positive test by a neutralization assay. If the neutralization assay comes negative, then a new specimen should be requested and or a recommendation that the patient be tested for other markers of infection. Some mutant HPS antigen can be missed by commercial assays. Okay, so this one is what we use to gauge. Okay, this one, as you can see here, to gauge the levels of this. So if it's positive, we know you have the disease. If it's negative, we know that you don't have the disease, but you'll require further testing. Remember, we have the occult hepatitis B infection. And then, yeah, so this is just how it works. You can read this. And then nucleic acid detection. So this is all about quantitative. Recommended for initial evaluation of chronic hepatitis B and during management. So here we want to see the number of copies or the viral copies in your blood, okay? So criteria for chronic hepatitis B, 20,000 international units per ml, okay? So this is the DNA, nucleic acid detection. It is the HBV DNA. And then biochemistry, here is where we do we call them liver function tests. Serum transaminases, ALT is greater than AST, but this reverses once cirrhosis sets in. So something very specific for viral hepatitis is Alanine transaminase, ALT, is usually raised more than AST. Okay? That is very specific for viral hepatitis. Normally, most of the diseases, for example, let's say you have alcoholic liver cirrhosis, AST will rise more than ALT. But for viral hepatitis, ALT rises more than AST. And then bilirubin, so direct and total, it will be raised. So this is why they have jaundice. You remember we said at the icteric phase, they have jaundice or the yellowness of the eyes. This is because the total bilirubin is raised. Albumin and total protein. So the liver produces albumin. Albumin is responsible for transporting. It is a protein. It's responsible for transporting electrolytes in your body, minerals, all those things. Okay, so the albumin level will be low because your liver is getting damaged. And as your liver is getting damaged, albumin is not being produced. Another one is coagulation tests, prothrombin time. So prothrombin time, remember, coagulation factors, I don't know if you've done this, but coagulation factors, factor 1, 2, 3, there are 13 factors. They are made in the liver. So if the liver is being damaged, your prothrombin time, so prothrombin time is a test that is used to check the activity of your coagulation factors. Okay, so if your liver is being damaged, your coagulation factors will not be produced. And when they're not produced, this time is going to increase. Okay, it will take more time for your blood to clot. The coagulation factors are also known as the clotting factors. And then alpha-fetoprotein, this is a marker of hepatocellular carcinoma. So if this one is raised, you'll know that the patient has liver cancer. Okay, so these are the biochemical tests used in the diagnosis of hepatitis B. Evaluation, interpretation, and reporting of results. So this one, I think we have gone through it properly. Unless you have a question. And then for treatment, this is also very high yield. We use, as I said, 99% previously healthy person recover and treatment is not required. We use interferon and then nucleoside analogs. Remember the ones we also used in HIV treatment? Lamivudine, adefovir, entecavir, telbivudine, tenofovir, okay? They are also used. Prophylaxis, recombinant subunit vaccine. So here is where you inject the patient with the hepatitis B surface antigen. Then you start producing the antibodies, okay? So this one is, it's mostly given to healthcare workers, people who are exposed to hepatitis B. So even you, when you get to, I think fourth year, yeah, when you get to fourth year, you know you're going to be exposed to patients who have these diseases. So you'll have to be given this vaccine. And then boosters are given after 5 years for high-risk group or antibody titer falls below 10 international units per ml. Then we have something called passive immunization. Here we give hepatitis B immunoglobulins. Should be given within 6 hours, but not later than 48 hours, okay? Here's the dose, and then the doses are given 30 days apart. If you give someone antibodies, so this is someone who you think has been infected, okay? Then say no to hepatitis B. Then for prevention, I think I've not put them on my slides, but prevention, maybe practice safe sex, avoid sharing needles, blood screening, avoid blood transfusion without screened blood, okay? So you look at the ways it's spread, then you try and prevent them. Any question?